Hey kids, how you boys doing?
Polyarteritis nodosa was first described in 1866. Authors reported an intermittent nodular appearance affecting arteries throughout the body, sparing large vessels as aorta, small vessels as arterioles, capillaries, and venules, and pulmonary vessels. And because nodular appearance had distinct pear necklace pattern, they called this condition as polyarteritis nodosa. The most recent definition of polyarteritis nodosa describes this disease as necrotizing arteritis of the medium or small arteries without glomerulonephritis or vasculitis of arterioles, capillaries, or venules, and without ANCA. As we see in both cases, the accent is on the size of the vessels. This disorder affects medium-sized arteries, and this condition is not associated with ANCA. So let's explain why these two features are important to us.
Listen, everybody, be calm, cooperate, and this will all be over in a minute.
In our body, we have three types of vessels. It's large vessels as aorta and its branches. It's medium vessels that supply blood to particular organs. For example, it's coronary arteries that supply blood to the heart, or mesenteric arteries that supply blood to the intestine, or renal artery that supply blood to the kidneys. And it's small vessels as arterioles, capillaries, and venules. Polyarteritis nodosa affects medium-sized arteries, and it's the main visceral arteries that supply our organs. It's important because we have a group of disorders called vasculitis that can affect blood vessels. And the key feature here is that some types of vasculitis affect mostly large vessels. Some vasculitis affect medium-sized vessels, and other types of vasculitis affect small vessels. In addition to this, some vasculitis are associated with ANCA and some are not. It turns out that polyarteritis nodosa affects mostly medium-sized arteries, and this vasculitis is not associated with ANCA. So these two features help us in differential diagnosis.
Pretty smart, huh?
Pretty smart.
To explain the logic of this disorder, we have to recall normal physiology. Here we have artery, and the function of arteries is to provide the blood flow, and we need to maintain normal blood flow to supply tissues with enough nutrients and oxygen for their function. In this case, let's take heart tissue, muscle tissue, testicles, nervous tissue, kidneys, and intestine. From physics, recall that blood flow is directly proportional to pressure difference, which in this case is not so important, and inversely proportional to the resistance of the vessel. And resistance is inversely proportional to the radius of the vessel. So the most important concept here is that the larger is the radius of the vessel, the lower is the resistance, and the higher is the blood flow. This is how our cardiovascular system works.
Oh, that's cool.
But sometimes something can go wrong. So on top we have endothelial cell somewhere in our organism, and in the bottom we have medium-sized artery. As any artery, it has endothelial cells, subendothelium, and internal elastic lamina. The most common trigger of polyarteritis nodosa is hepatitis B infection. The reason is that in some cases, hepatitis B infection can cause severe injury to endothelial cells of the blood vessel. With injury, internal content of endothelial cells and subendothelial matrix becomes exposed, and usually this do not happen. Hepatitis B infection is such a common trigger that we even have positivity for hepatitis B virus as diagnostic criteria. So, if person has hepatitis B virus, it significantly increases the probability of diagnosis. The problem here is that in normal condition, internal content of endothelial cells is hidden from immune cells. So, our immune cells do not used to see such massive amount of endothelial cell debris or subendothelial matrix in the blood. So, when suddenly endothelial cells' internal content comes into the blood, macrophages phagocyte these endothelial cells particles, and macrophages present some parts of the endothelial cells on MHC2 receptors to T helpers. The logic is that antigen-presenting cells want to know, is endothelial cells particles normal material or is something pathogenic? T helpers scan endothelial cell particles, and in normal condition, T helper recognize them as normal substances, and because of this, they do not trigger inflammation. But some people have genetic intolerance to endothelial cell particles. The problem here is that predisposed individuals have MHC2 receptors that are produced based on HLA genes, which do not have information about the internal content of endothelial cells.
Is that a fact?
No, it's not a fact. It's just what I heard. It's just what I heard.
Who told you?
They?
And in these individuals, T helpers think that these endothelial cell particles do not belong to our organism. So in this case, basically, T helpers recognize endothelial cell particles as antigens.
All right, let me explain something to you, Mr. Black. You know who I am, I know who you are.
Perhaps. But appearances can be deceptive.
Yeah.
And antigens means danger. So in response to antigens, T helpers becomes activated.
As soon as you give us the money, dickwad! You fuck! Give it to me, fuck! You fucker! I know who you are, fucker! You're the fucker!
Once T helper becomes activated, T helper induces activation of B lymphocytes. If B lymphocytes becomes activated, they begin to produce antibodies. In this case, B lymphocytes begin to produce antibodies against endothelial cell particles. Such antibodies we call anti-endothelial cells antibodies. These anti-endothelial cells antibodies bind to endothelial cells particles with formation of immune complexes. In this case, immune complex is composed of self-antigen, which in this case are endothelial cell particles, and antibody. In this case, it's autoantibodies against endothelial cells. The problem here is that these immune complexes can activate complement. In normal condition, complement circulates through the bloodstream in an inactive state. But once immune complex binds to complement, complement immediately becomes activated. Activated complement together with immune complexes cause direct damage to arterial vessel wall. Let's suppose that we have three areas with different severity of damage, from mild damage that affects endothelial cells and subendothelium to severe damage that affects also internal elastic lamina. In addition to direct damage, activated complement attracts monocytes and neutrophils to the site of inflammation. So basically, neutrophils and monocytes infiltrate the affected area, where they potentiate inflammation. And recall that once monocytes enter into the tissue, they become macrophages. Activated monocytes and neutrophils at the site of inflammation begin to produce pro-inflammatory cytokines, as tumor necrosis factor alpha and interleukin-1 beta, which cause systemic symptoms as weight loss and fever. Additionally, with activation, T helpers activate T killers, and activated T killers massively infiltrate the affected area, and by this they also potentiate inflammation. In addition to this, with inflammation, permeability of the blood vessel increase, and fibrin from the blood begin to leak into the affected area. Inflammation causes destruction within the blood vessel wall, and naturally we try to repair the damaged area by deposition of connective tissue, which serves as biological glue. So, in response to such a severe inflammation, fibroblasts within the blood vessel wall begin to produce massive amount of collagen, and collagen molecules begin to deposit within the blood vessel wall. Tissue necrosis, which is characterized by the presence of fibrin and immune complexes within the blood vessel wall, we call fibrinoid necrosis.
You know what I'm saying?
It's an interesting point. Come on, let's get into character.
In this case, fibrinoid necrosis also is accompanied by massive neutrophilic and lymphocytic infiltration. As we see, there are no granulomas formation, and inflammation potentially can affect all layers of the blood vessel, so it's transmural inflammation. In response to fibrinoid necrosis, organism produce massive amount of collagen that begin to deposit within the blood vessel wall, and with deposition of collagen, vessel become more narrow and stiff. The state of arterial wall we can determine on biopsy, and the specific changes in medium-sized arteries as infiltration of arterial wall by granulocytes means its infiltration mostly by neutrophils, and infiltration by mononuclear cells, its monocytes, macrophages and lymphocytes, also the presence of fibrinoid necrosis. All of this tell us about Polyarteritis Nodosa, so it's the second diagnostic criteria. The major problem here is that deposition of collagen within the blood vessel wall will cause narrowing of artery, which in turn will cause decrease in blood flow. So the income of blood to certain tissues will decrease, which will cause ischemia, and ischemia will cause severe clinical symptoms. The second problem is that in the most severe cases, when internal elastic lamina becomes affected, Polyarteritis nodosa can cause weakening of arterial wall, which will cause formation of microaneurysms. And the problem with aneurysms is that they can rupture, which will cause severe bleeding. So let's briefly review what we already know. The most common trigger that initiates Polyarteritis nodosa is hepatitis B virus. But nowadays we know that this disorder can also occur secondary to some genetic syndromes and secondary to some hematological disorders. Polyarteritis nodosa typically causes segmental necrotizing transmural inflammation. Segmental means that only a small segment of artery is affected. Necrotizing means that inflammation causes fibrinoid necrosis within the blood vessel wall. And transmural means that potentially inflammation can affect all layers. Fibrinoid necrosis within the arterial wall with time can be complicated by formation of microaneurysms, which can progress to aneurysms, and in turn, aneurysms can rupture, which will cause severe bleeding. On site of inflammation, cellular infiltrate is typically composed of T lymphocytes and neutrophils, and important that this disorder do not cause granulomas, because we have, for example, Wegener vasculitis or Charles-Strauss vasculitis that cause granulomas formation. Typically, this disease affects multiple blood vessels at the same time, and the stage of vascular inflammation in every vessel can be different. With inflammation, the level of cytokines increase, which will cause some systemic clinical symptoms, as fever for example. Histochemical studies also typically show the presence of macrophages and T lymphocytes on site of inflammation. And because hepatitis B virus is the most common trigger of Polyarteritis Nodosa, every patient should be tested for hepatitis B virus. So to summarize, Polyarteritis Nodosa causes fibrinoid necrosis, which can cause microaneurysms. Microaneurysm leads to aneurysm, and aneurysm can rupture, which will cause severe bleeding. Also, fibrinoid necrosis can cause severe scarring of the blood vessel, which with time can be complicated by stenosis of the blood vessel, and stenosis leads to severe ischemia. So, how these pathological changes in arterial wall cause clinical symptoms? So, immune complexes and activated complement cause severe injury to endothelial cells of the medium-sized arteries. In response to injury, body begins to fill these damaged areas with massive amount of collagen, and massive deposition of collagen within the blood vessel wall cause stiffening and narrowing of the artery. The problem here is that because injury causes narrowing of the arterial wall, the radius of the artery decreases. With decrease in radius, resistance increases, and with increase in resistance, blood flow decreases. So, inflammation in Polyarteritis Nodosa causes decrease in radius of the vessel, which in turn causes decrease in blood flow through the vessel. This results in decrease in blood supply of tissues, and now tissues will have deficiency of nutrients and oxygen, and this state we call ischemia. Decrease in blood supply to heart tissue will cause myocardial ischemia, and myocardial ischemia can manifest as angina, prolonged ischemia can cause myocardial infarction, and with time even heart failure can develop. As we see in some guidelines, cardiac symptoms are among the main diagnostic criteria of Polyarteritis Nodosa. A decrease in blood supply to skeletal muscle tissue will cause ischemia in the muscle tissue, and most commonly muscle tissue ischemia manifests as myalgias, muscle weakness, and leg tenderness. As we see, muscle symptoms are among the crucial diagnostic criteria of Polyarteritis Nodosa. Decrease in blood supply to testicles causes testicular ischemia, which typically manifests as pain and tenderness in the testicles.
What?
Now, this is very unfortunate clinical manifestation, but also it's a very specific clinical symptom, because the only vasculitis that can cause pain in testicles, except Polyarteritis Nodosa, is Behçet disease. So, it's a crucial symptom in differential diagnosis. And as we see, it's one of the diagnostic criteria in American guideline.
There's something very wrong with this.
Decrease in blood supply to nervous tissue causes nervous tissue ischemia, which manifests as mono or polyneuropathy. And neural tissue involvement is such a common feature of Polyarteritis Nodosa that it's present in every guideline among the diagnostic criteria. Decrease in blood supply to kidney tissue causes kidney tissue ischemia, which manifests as kidney injury. And as we know, kidney injury causes increase in blood creatinine level, increase in blood urea level, and also it leads to a malignant hypertension. As we see, kidney injury with elevated urea and creatinine levels and hypertension are one of the crucial diagnostic criteria of Polyarteritis Nodosa. Decrease in blood supply to intestine will cause mesenteric ischemia, and mesenteric ischemia or mesenteric infarction, which is also possible, manifest as severe pain in the abdomen. Intestinal manifestations are also one of the diagnostic criteria of polyarteritis nodosa. In addition to this, immune complexes can deposit on pericardial tissue, which can cause pericarditis. Deposition of immune complexes in the joints can cause arthritis, and deposition of immune complexes in the skin tissue can cause formation of nodules, livido reticularis, purpura, and ulcers. As we see, skin manifestations and arthritis with pleuritis are among the major diagnostic criteria of polyarteritis nodosa. In some cases, severe vessel wall injury can cause formation of microaneurysms, and aneurysms can be complicated by rupture that will cause severe bleeding. In addition to this, deposition of immune complexes can cause severe inflammation with massive release of cytokines, and cytokines cause systemic clinical symptoms as weight loss and fever. Also, they cause increase in erythrocyte sedimentation rate and increase in white blood cells, mostly due to the increase in neutrophils. As we see, general clinical symptoms as fever and weight loss are among the major diagnostic criteria. And obviously, pathological changes in the blood vessels we can determine by angiography. So the presence of aneurysms or occlusions in medium-sized arteries are also the crucial diagnostic criteria.
What's your thoughts on how to handle this?
What's yours?
In treatment, we have to know that we have two major agents. It's cyclophosphamide and intravenous glucocorticosteroids, as methylprednisolone, for example. Exactly these two agents will be the right choice on examination.
I think that's the shit, man.
But also, in non-severe disease, we can use agents as methotrexate or azathioprine. So, let's finish with a clinical case. Obviously, we already know that this case is about polyarteritis nodosa, but let's highlight the signature features of this disorder. It's a 38-year-old man. 1 week prior to presentation, he had skin rash on his ankles, and we know that skin rash is a very common manifestation of practically any vasculitis. Rash resolves spontaneously, but also in the same time, he developed left temporal headache accompanied by fever and chills. So he has systemic symptoms as fever and chills, which are also characteristic features of vasculitis. In addition to this, he experienced left jaw pain with eating. But while left temporal headache and pain in the left jaw can also be manifestations of polyarteritis nodosa?
I don't know. That's a good question.
To explain this, here we have blood vessel. Blood vessel delivers blood to tissues. In this case, let's suppose that it's masseter muscle that provides movement of the left jaw. And we know that blood flow is equal to pressure difference divided on resistance, and resistance is inversely proportional to the force power of radius. In polyarteritis nodosa, vessel wall injury causes massive scarring, and scar tissue significantly narrows arterial lumen. So deposition of fibrous tissue causes decrease in radius of the vessel. With decrease in radius, resistance increase. With increase in resistance, blood flow decrease. And decrease in blood income to masseter muscle causes muscle tissue ischemia, which manifests as pain in the left jaw.
Pretty smart.
Yeah, I got my moments.
Also, he had sudden vision loss and abdominal pain after meals. Abdominal pain is also a characteristic feature of polyarteritis nodosa because it can be a sign of mesenteric ischemia. And association of abdominal pain with meal It's a signature feature, because intake of meal causes increase in blood demand in intestinal tissue, and if vascular occlusion is present, meal intake can provoke the ischemia episode, and ischemia manifests with pain.
Have I made myself clear, boys?
Yeah, that's perfectly clear, Mickey, yeah. Just give me 1 minute to confer with my colleague. Did you understand a single word of what he just said?
Also, he had weight loss, and weight loss is also one of the diagnostic criteria. He had stenosis in the past, but doctors thought that it was caused by dyslipidemia. He had hypertension, and we know that hypertension is also one of the symptoms of Polyarteritis Nodosa. Bruits can be manifestations of severe stenosis, and we know that vessel wall injury caused by Polyarteritis Nodosa leads to deposition of massive amount of collagen within the vessel wall, which can cause stenosis. Also, he had muscle tenderness, which is one of the diagnostic criteria. He had elevated white blood cell count due to the increase in neutrophils, and his erythrocyte sedimentation rate is 61, which tells us about severe inflammation. He had elevated C-reactive protein, which also tells us about inflammation, and he had low complement level in the blood, which can be a sign of hyperactivation of complement, and hyperactivation of complement is a common feature of autoimmune disorders accompanied by severe inflammation. On biopsy, they determined lymphocytic infiltration of several layers within the blood vessel wall, and on MRI, they determined significant stenosis of mesenteric arteries and renal artery. In addition to this, he had stenosis of carotid artery and cerebral artery, and we know that stenosis can be a sign of Polyarteritis Nodosa. After 6 days of intravenous methylprednisolone, complete resolution of symptoms was achieved, and he was discharged home.
Good. Great.
Here we can see right temporal artery biopsy, and on the right we can see severe stenosis between the middle cerebral artery and anterior circulation.
Well, what did he do that for?
Don't know, sir.
A month later, patient again had recurrent headache, fever, chills, general malaise, and intense abdominal pain.
Wait a minute.
His blood pressure was 230, which is huge, and he had elevated creatinine level 2.3 milligrams per deciliter. It's approximately 200 micromoles, so it's 2 times higher than normal, which tells us about the renal failure.
You know what they call a quarter pound of a cheese in France?
No.
Tell them, Vincent.
Royale with cheese.
Royale with cheese. You know why they call it that?
Because of the metric system?
Check out the big brain on Brad. You're a smart motherfucker, that's right. The metric system.
Also, he has cardiomyopathy and progressive worsening of stenosis in previously affected arteries. In the end, he developed mesenteric ischemia with evolution into sepsis and cardiac arrest, and unfortunately, he died on the 7th hospital day.
That's a damn shame.
Biopsy revealed healing vasculitis of large and medium-sized arteries and fibrin thrombosis in a few vessels. So, based on clinical symptoms, biopsy findings, a diagnosis of Polyarteritis Nodosa was made.
What did we learn, Palmer?
I don't know, sir.
I don't fucking know either.
And?
And nothing. That's it.